Management of alloimmunization during pregnancy. So nomenclature, we use the Fisher race nomenclature. There's actually no little d antigen, just absence of big D. Rh negative, 15% of whites and 2% of Asians. Weak D positive, it's a heterogeneous group of D variants. Lewis and I do not cause erythroblastosis fetalis. Kel produces erythroblastosis fetalis. Also, Kel does not correlate with patient's sensitization to Kel, so the titer doesn't mean much. Causes of alloimmunization, 50% of cases is during delivery, 5% is from antepartum fetal maternal hemorrhage. There's also possible from first trimester abortion, ectopic pregnancy. Prevention, there is no need if the patient is already sensitized to D. If sensitized to other blood group antigens, should still have anti-D immunoglobulin. Screening, first visit, and before giving anti-D immunoglobulin, and also postpartum. Significant risk of erythroblastosis fetalis or hydrops is titer level 1 to 8 to 1 to 32. If the initial titer is 1 to 8 or less, we monitor the titer every 4 weeks. K titer does not correlate with severity. Ancillary tests, initial management is determined. The first step in management is to determine the maternal erythrocyte antigen status. If the father is negative and so the FOB is certain, then no further testing is done. If positive, determine the use. Okay, so we need to determine the uh, if the father is antigen positive, then we need to determine the heterogeneity and whether the father is heterogeneous or homogeneous by using a DNA analysis. Determine the phenotype, then we determine the phenotype, amniocentesis, if the paternal type is heterogeneous. Positive predictive value is 100%, negative predictive value is 97% with a false negative rate of 2%. Further testing is usually not needed. However, periodic non-invasive assessment might be needed due to the false negative rate. Fetal MCA velocity to evaluate fetal anemia, height rate of false positive rate after 34 weeks. What is the management of non-anti-D antigen in the at first prenatal? 2% of OB patients will have non-anti-D antigen positive, usually caused by blood transfusion. These patients are followed with MCA Doppler. Delivery timing, if mild fetal hemolysis, we can deliver between 37 to 38 weeks. Severe sensitized pregnancy require multiple invasive procedures. Neonatal survival rate after 32 weeks is usually 95%. We should try to deliver these fetus between 32 to 34 weeks. Critical titer between 1 to 1 1 to 8 to 1 to 32. Fetal assessment every 4 weeks should be done with MCA Doppler starting at 16 weeks. Chorocentesis for MCA Doppler greater than 1.5 of normal. We need to do chorocentesis. If the fetal hematocrit is less than 30%, might need transfusion. Anti-D 1 to 8 or lower titers can be monitored with maternal antibody titers. If greater than 1 to 16, fetal wellness assessment is mandatory by ultrasound to evaluate the MCA peak velocity or serial amniocentesis for delta OD150. So basically, if it's less than 1 to 8, we can monitor with maternal antibody titers. If it's greater than 116, fetal wellness assessment with ultrasound to evaluate MCA Dopplers. Deliver at 32 weeks if severe high drops. Like I said, mild hemolysis can be delivered between 37 and 38 weeks. So ABO incompatibility is something different. The maternal ABO antibodies are IgMs and they do not cross the placenta. They will only cause postpartum jaundice in the baby. Neonatal autoimmune thrombocytopenia is a maternal antibody developed against the fetal platelets. It's very rare, 1 in 1,000 live births. All subsequent pregnancies will be affected if if there's a prior affected baby. We need to give weekly IVIG or steroids starting around 12 or 20 weeks depending on prior severity.